Okay. Kalau semua orang dah ada, then can just start lah.
Okay, Doctor. So, a very good afternoon. I bid to my classmate and our dearest lecturer, Dr. Chen. And in today's session, our group will be presenting and covering several topics, which include children with special needs, mental retardation, adolescent health problem, and lastly, palliative care. So I will be your first presenter for today's session. My name is Adila Jasmine Azhar. This is the outline of my presentation. We will start with definition, followed by epidemiology, type of children with special need, evaluation of children with special need, goals of management, and children with disability in Malaysia. So the definition of children with special need is, according to Person with Disability Act 2008, is a person with disabilities include those who have long-term physical, mental, intellectual, or sensory impairment, which in interaction with various barriers may hinder their full and effective participation in society on an equal basis with others. For epidemiology, according to WHO, approximately 15% of the world population live with some form of disability, and 1.5% of the total Malaysian population are estimated to be living with disabilities. And according to Ministry of Health Malaysia, a total of 22,089 child with special needs is registered from 2004 to 2012. So types of children with special needs are classified according to hearing, vision, speech, physical, learning difficulty, mental, and various problems. So we go to the first classification, which is hearing impairment. So hearing impairment or hearing disabled is defined as children who are unable to hear clearly in both ears without hearing aid, or unable to hear at all even with hearing aid. So hearing impairment can be divided into sensory neural, conductive, or mix of both, combination of sensory neural and conductive hearing loss. So there are many causes. For example, in conductive hearing loss, it can be caused by otitis media, eustachian tube dysfunction, or wax, while sensory neural can be caused by genetic, congenital infection, preterm, hypoxic ischemic encephalopathy, hyperbilirubinemia, while in postnatal, it can be due to meningitis, encephalitis, head injury, drugs, and neurodegenerative disorder. In conductive hearing impairment, the management consists of conservative and amplification or surgery, while in sensory neural, it can be due to amplification or cochlear implant if necessary. And the most common cause of mild to moderate hearing impairment due to conduction abnormality, which is caused by acquired middle ear disease, which are acute and chronic otitis media. While if the hearing impairment is severe, it is usually due to sensory neural causes and commonly caused by congenital infection, meningitis, birth asphyxia, chronic thirst, and ototoxic drug. And hearing impairment can be classified according to the severity, into mild, moderate, severe, and also profound. Mild is from 15 to 29 decibels, which means that the child cannot hear at that level. Moderate 30 to 59 decibels. Severe is 60 to 89 decibels, and profound 90 decibels or more. For your information, mild, which is around 30 decibel, is equivalent to someone whispering to you. That is 30 decibel. If someone talking, normal conversation, like I'm talking to you, it is around 60 decibels. While severe, around 90 decibels, it is sound of running motorcycle engine. Okay. Oh my God. Okay. The table is missing. Sorry. So I'm sorry, I have to change because the table is missing here. Sekejap.
Change the color of the wording
Oh,
there.
color.
Yeah.
Okay, okay. Okay, so for visual impairment, visually disabled is defined as blind in both eyes or limited vision in both eyes or any other permanent visual disturbance. While low vision is defined as worse than 6/18 but equal to or better than 3/16, even with visual aids. And blindness is defined as have visual acuity less than 3/60 or visual field less than 30 degrees from fixation. So the cause of visual impairment can be divided into genetic, antenatal and perinatal, and also postnatal. For genetic, it can include cataract, albinism, and asthma. Antenatal and perinatal can be due to congenital infection, retinopathy or prematurity, hypoxic ischemic encephalopathy, and cerebral abnormality. While postnatal can be due to trauma and also infection. Okay. Okay. So if you still remember how we read the visual acuity result, the first number, for example, we look at the 6/18. 6/18. 6 means that the distance between the patient and the snail chart, while 18 is the distance that normal person can read the letters. Okay. So sign in infancy which indicate that the child might have visual impairment include loss of reflex, not smiling responsively by 6 weeks, lack of eye contact with parents, visual inattention. Oops. Okay, visual inattention, random eye movement, nystagmus, squint, and also photophobia. Okay, the third disability is speech and language disability. Speech disability is defined as inability to speak that impair proper communication and cannot be understood by those who interact with the person. And speech and language disorder include disorder of language comprehension, language expression, phonation and speech production, pragmatic social and or communication skill. Other causes of speech and language disability include hearing loss, global developmental delay, difficulty in speech production, and environmental deprivation. Okay. The fourth category is physical disability. So physical disability refer to permanent inability of the part of the body caused by loss or absence or inability that can affect their function in fully carrying out basic activities. And the causes of physical disability include limb defect, including loss of thumb, spinal cord injury, stroke, traumatic brain injury, dwarfism, and cerebral palsy. Okay, next is learning difficulties. Can you see the slide?
No.
Okay, learning difficulties. This refer to intellectual capabilities that do not conform to with the biological age, and those can include those that fall within this category include late global development, Down syndrome, intellectual disability, learning disability, autism, ADHD, and specific learning difficulties such as dyspraxia, dyslexia, dyscalculia, and also dysgraphia. Okay, next is mental disability. This refers to state of severe mental illness that causes an inability to function in person, whether partly or fully. Under mental disability include organic mental disorder, schizophrenia, paranoia, mood disorder, and psychotic disorder. So, in children with special need, we have to do several assessments, which include medical assessment, motor assessment, and so on. So, under medical is to identify the cause of the developmental dysfunction, identify and interpret other medical conditions that have a developmental impact. And the third one is to take comprehensive history and physical examination, which this include careful graphing of growth parameter and accurate description of dysmorphic features. For example, in history taking, we have to ask several questions. For example, regarding the prenatal, we ask the mother about the children during prenatal period. Is the mother taking any alcohol, drug, any maternal infection? And during neonatal period, is there any respiratory distress, seizure, or the children experiencing diagnosed with hyperbilirubinemia? Okay, and then don't forget to ask about family history. This is important, especially in us if the marriage is consanguineous, which increase the risk of certain disease. And social history asks about the education background, the socioeconomic background of the family, and also particularly the mental health problem of the family, the parents. Okay, next, the second one is motor assessment. This include comprehensive neurological examination. Okay, we do complete neurological examination on the children, and we do an age-appropriate adaptive functional evaluation by specialists and therapists. Okay, the third evaluation includes psychological assessment. This is to test the cognitive ability, and then we evaluate the personality and emotional well-being, and we measure the IQ and mental age score. Okay, so there are several tests under the cognitive test. Okay, and it depend on the children age. For example, in preschool, the test that we use is a Wechsler primary and preschool test of intelligence. In school age, we use a Wechsler intelligence scale for children, and other tests include Vinland adaptive behavior scale. Okay, and then we do educational assessment. This is to evaluate areas of specific strength and weakness in reading, spelling, written expression, and mathematical skill. After we have assessed the education level of these children, we can develop the individualized educational plan. Okay, lastly, social assessment. This include the home visit to the children's house, which this can provide more comprehensive evaluation for the children. For example, we want to identify the possible causes of the developmental delay in children, and then suggest additional adaptive equipment or renovation for the children, especially children with special need, and refer local protection agency for suspected neglect or abuse. Okay. After we have done all the assessment and diagnose the children with special need, okay, the goal of management, we have to treat the children. So the goal of management is to maximize the child potential for productive adult functioning by first treating the primary diagnosis, and second one, help the patient and family deal with the stresses and secondary impairment. Okay. So whenever a chronic disease is diagnosed in children, usually the family members will grieve and show anger. The family members will have a denial or show sign and symptom of depression. So a supportive physician can facilitate the process of acceptance by educate the family members and by help to relieve the guilty feeling or fear in the family members, especially in children with special needs. So Malaysia and our government have undertaken several acts to cater with children with disabilities in Malaysia, which include early detection and intervention, healthcare program, education, social protection program, and lastly, Protection Act. Okay, for early detection and intervention, especially Ministry of Health, MOH have provide the health record for baby and child. I'm sure most of you are very familiar with these books. The pink one is for the girl and blue one is for boys. Okay, so we can assess and track the child development. And then Ministry of Education have established the literacy and numeracy screening, or we call it as Linus. So Linus they have specific level of children, specific, to say. At certain age, the children should have able to read or achieve certain certain level of literacy at certain age. Okay, and healthcare program include government hospital and health center. They provide trained occupational therapists, physiotherapists, and social worker. The next one is community-based rehabilitation center. There are one-stop center intended to provide diagnosis, rehab, treatment, special education, and also vocational training. The third one is health screening program. There are yearly health screening for students in year 1 and 6 in primary school and form 3 in secondary school, which include the physical examination, eye examination, and hearing assessment. If you remember, we have been involved in this assessment during our school years. Okay, and then education. Malaysia also have established special education school, special education integrated program, and also private sector education center to cater with the needs of children with disability. And on your right side is a protection program. So monthly cash allowance of 150 ringgit is provided by Ministry of Education in primary and secondary school for children with disability. And there are also establishment of Taman Sinar Harapan home, which provide residence care and rehabilitation for these children. Okay, lastly for my part is Protection Act. There are Child Act which cover 12 categories of children in need of protection, which include cases of physical, sexual, mental, and emotional abuse, ill treatment, neglect, and abandonment. So in this act, in this Protection Act, it allows the authority to take over temporary custody or remove to a place of safety for the child, which in need of care and protection, and to conduct medical examination and treatment for the children. And it also remove a child. This act also allow for the authority to remove a child to a place of refugee or safe place for a child that we see in need of protection and rehabilitation. So that's all for my part, and these are my references. Is there any question? If there are no questions,
Adila, can we just
Yes?
go through the slides again from the beginning? Just quickly, just go through again from the beginning. Okay. Just flip slowly. Jasmine, Adila, Jasmine, just
Yes. Yes, I
next.
cannot hear
Can you
you.
just flip it, please? Can you just flip it, please? Yeah, flip, just continue until I say stop.
Okay. Okay.
Okay, stop. Flip back one slide. Go back one slide. Another slide. Okay,
Forward
another
and
slide. Flip back another slide. Backwards.
backward.
Backwards. Okay. Next. 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 Now, all these things is what is ideally should be done, but then you guys realize that in real life, not all things are done as it's supposed to be. So the nearer you are to KL and PJ, it seems the better things tend to be in terms of community-based rehab, in terms of occupational therapy, in cases of physical therapy. Like if in Kuantan, there's a PDK right behind the hospital, pendidikan dalam community right behind the hospital, but it's not very ideal because it mix all sorts of disabilities together, and the range of disability there is also a bit too wide. All right, you cannot bunch a whole lot of people with different abilities and different levels of understanding together. Even the NASOM, which is in Kuantan. Any of you know where NASOM is not? In Kuantan? Any idea?
No.
No.
Okay, Laila Wadi tahu?
Tahu.
Laila Wadi tahu kat mana?
Oh,
Laila Wadi tahu?
tahu. Tahu.
Tahu kan? Tempat makan tahu?
Tahu.
Wait, I'm talking. Running through, we have 3 online classes going on at the same time. Okay. Anyway, Laila Wadi tahu kan? Tempat makan tahu lah juga. Laila Wadi is behind Laila Wadi. The
Doktor. Doctor, we cannot hear you.
Dr. Telan.
Okay. Hi, sorry. Sorry about that. My Wi-Fi just disconnected. Anyways, okay. Nasom, is it Nasom? Yeah. It's behind Laila Wadi. It's along that road. But anyway, if you were to go there, so it's like less than ideal. They supposedly have a sensory room, but nobody uses it because the occupational therapist that is supposed to go there, obviously la pandemic lah, but even before the pandemic, also the occupational therapist that was supposed to go there didn't go there. Okay. The sensory room is basically the same one like the one in UIA. UIA also has a sensory room for the autistic children, right? It's basically the same thing. But even if, have you guys ever gone into that room? The sensory room?
Yes, doctor.
Okay.
Yes.
Have you gone in together with an occupational therapist? When there's patients there, have you gone in there?
No.
We went
No,
there with the
okay.
Only
OT.
once. Some
No.
Okay,
some
with
of
the
us.
with the OT, with a patient, I'm assuming, or just the OT?
No patient. We just like have a simulation.
Okay, but anyway, just based on experience lah, just because a lot of the occupational therapists, especially the ones in Kuantan, including the ones from UIA, do not deal enough with children with autism. So when they interact with these children, these children is not, the problem is not that they don't want to interact. The problem is that they don't know how to interact, right? So the issue here now is that the therapist, whoever it is, whether you, the parent themselves is the therapist or the teacher is the therapist need to learn how to interact with the patient. A lot of times they are unable to get the child to do what needs to be done in a playful way, right? So if the kid's not interested, whatever you have in front of them, also they won't be able to use it properly. So basically training lah. The therapists don't get enough training with children on the spectrum, because the spectrum is it's called a spectrum for a reason, isn't it? Right? You have the mild, very mild ones which might not be noticeable at all, and you have the ones that are on the severe end who are so-called classically within their own world, self-stimulatory behavior, unable to communicate, those sort of things. But even the children who are on the severe end of the spectrum should be able to communicate in some form, whether it's verbal or non-verbally. It's a matter of the people surrounding them being able to pick up on what needs to be done, and both sides need to learn how to communicate basically. Right. So where was it? Special education school, integrated programs. So these are schools where you have normal, so-called normal, nobody's normal anyway. Kids going to normal school, and then you have kids with, usually those with hearing impairment. That I think the one in Bukit Skilau is an integrated school. So kids with hearing impairment and kids with no disabilities go to the same school, and they share certain classes. Most of the private sector education centers, especially the ones with autism centers, most of them are in KL and PJ, right? So if you are in somewhere like even just Kuantan is not that backwater, isn't it? But then there's actually, in terms of private education centers for children with special needs, we don't really have any. Monthly cash allowance, $150 actually doesn't do much, because if children with special needs get proper therapy is minimum once or twice a week. Even speech therapy, minimum is once or twice a week. Government cannot supply because not enough speech therapists, and there's too many patients to see them that often. So usually, if the parents really want to send the children for speech therapy, then they have to rely on private speech therapists. If you go for private speech therapists, one session is already $150. So the $150 actually doesn't stretch a lot. right? Even physical therapy, even occupational therapy, if you were to rely on just government centers, is a very difficult. You're probably just going to get appointments once every 3 or 4 months. Obviously, parents going to do it at home also lah, but it's very stressful if you are the only person you can rely on, right? So therapy helps, but if they were to go privately, it's $150 per session. If he goes for both occupational therapy and speech therapy and behavioral therapy, that's like already $500 a week, right? So that $150 doesn't really stretch much. Next, Jasmine. Next. Okay. Okay. Alawiyah. Now, honestly, you shouldn't use this term any longer, mental retardation, right? Because it's derogatory meaning that it's demeaning. It's a term that is very, in this age, it sounds very demeaning. Because previously, when you call somebody a retard, it's basically you're insulting the person, right? So that word retardation has a negative connotation to it. So nowadays, we tend not to use this term, especially if you're overseas in the Western countries. Please do not use this term when you're referring to somebody who is mentally deficient. Okay? Alawiyah nak.
Okay, doctor.
Betul kan? Did you touch on that? The retardation part?
No. Later I will use the term intellectual disability.
Yeah, but honestly speaking, because we are in Malaysia, we tend not to, I guess, well, how do you say this? To us, it's just a term, right? But if you were to go to the US and the UK, and if you were to continue using this term, a lot of people will take offense, okay? Because it's not a very nice term to use any longer. Because retardation and the word retard itself is used historically as an insult, right? So it's associated very negatively. So please do not use this term lah if you can. Okay. So either intellectual impairment, some people say, I mean, even if you're talking about whether the child has disability, also nowadays people tend to say differently abled rather than disabilities, isn't it? Right. Continue.
Okay, doctor. So I will use the term intellectual disability actually here. The mental retardation is based on the schedule. So for the definition based on up to date, intellectual disability is a neurodevelopmental disorder that begins in childhood and is characterized by limitation in both intelligence as well as adaptive skills. And this adaptive skill affecting at least one of three domains, which are conceptual, social, or practical. And the onset of deficit is due before the age of 18 years old. And we are quite familiar with the term ID during our psychiatry posting. We have the DSM diagnosis, which is it is a deficit in intellectual functioning, which are reasoning, problem solving, planning, abstract thinking, judgment, academic learning, and learning from experience, which is confirmed by clinical evaluation and individualized based on standard IQ testing. And there are also deficits in adaptive functioning that significantly hamper conforming to developmental and social cultural standards for the individual's independence and their ability to meet their social responsibility. And the onset of this deficit is during childhood. For the intellectual functioning, the diagnostic criteria for intellectual disability required that an individual score, which is 2 standard deviations or below the mean, which is the IQ score is less than 70 or it is roughly below the third percentile. But in this DSM-5 IQ score have been re-emphasized, and there is no longer a cut-off score or threshold per se for establishing a diagnosis. It is rather a scale. IQ scores are evaluated in context of individuals' entire clinical picture. For the adaptive function, as I mentioned before, there are three domains: conceptual, social, and practical skill. For conceptual, we have literacy, which are language, reading and writing; mathematics involving money, time and number; and abstract theoretical reasoning, memory, self-direction, and judgment in situation. For social skill, it is interpersonal social communication, empathy, ability to relate to peers as friends, social problem solving, and social responsibility and self-esteem. They also include gullibility, which is the ability to follow rules and avoiding victimization. For practical skills, it involves daily living skills, which is eating, dressing, mobility, and toileting, as well as additional skills following a schedule or routine, using a telephone, managing money, preparing meals, occupational skills, and abilities in transportation or travel, and as well as healthcare and safety. There are severity based on DSM-5. They have mild, moderate, severe, and profound for each domain. For conceptual just now, for mild, it requires academic support. For moderate, it may learn up until elementary level. And severe, they have little understanding of written language or number, time, and money concept. And profound, they may use object on goal-directed fashion for self-care. For social, mild is social skills and personal judgment are immature. For moderate, they regularly need support in terms of social. For severe, they may use very basic single words, phrases, or gestures. And profound, they can express only non-verbally. For practical skills, in mild, they are mostly independent. For moderate, independent self-care with moderate support. For severe, individuals are trainable in some basic action in daily life, and for profound, they are totally dependent on other people. Okay, for assessment, we have the tools for intellectual function as well as adaptive function. For intellectual function, there are a few: bachelor, preschool, and primary scale of intelligence, Bailey scales of infant development, standardized intelligence test Kaufman, assessment battery for children Stanford Binet, and intelligence scale Griffith's mental developmental skills. But based on during our previous psychiatry posting, it is said that bachelor, preschool, and primary scale of intelligence is the most used assessment tool. For adaptive function, we have Vineland Adaptive Behavior Scale, VABS, Diagnostic Adaptive Behavior Scale, as well as Adaptive Behavior Assessment System. And the mostly used tools is Vineland Adaptive Behavior Scale. These are the example for bachelor, preschool, and primary scale of intelligence. It's based on the age, and they have their full scale or either full scale or primary index scale. Next. And these are the numerical score for intelligence. If it is below 7, it is extremely low. If it is 130 and above, it is very superior. And on average, it is between 90 to 109 score. And these are example of Vineland Adaptive Behavior Scale. They have 5 domains. The first one is communication, consisting of receptive, expressive, or written, and daily living skill, personal, domestic, and community. Socialization, interpersonal relationship, play and leisure time, and their coping skills. For motor skill, fine and gross, and maladaptive behavior index. This is optional: internalizing, externalizing, and others. So for etiology of intellectual disability, we can divide it into prenatal, perinatal, and postnatal. For prenatal, maybe the person have chromosomal disorder, for example, Down syndrome or Fragile X syndrome, or the mother have the baby have intrauterine infection, or there are inborn error metabolism, or the mother have drug ingestion, for example, phenytoin, mercury, or alcohol consumption, and the mother is exposed to radiation, for example, lead exposure. For perinatal, and maybe because of preterm birth infection, hypoxia, intracranial hemorrhage, or trauma. For postnatal, they can be accidental or non-accidental injury, or the baby have CNS hemorrhage, CNS malignancy, environmental toxin, malnutrition, metabolic or endocrine, for example, hypoglycemia or hypothyroidism, as well as psychosocial deprivation. These are examples of children with intellectual disability. As we all know, we are well known about Down syndrome. We also have DGEORGE syndrome, which is the microdeletion of chromosome number 22, and the feature may vary widely. Here in the picture, there are mnemonic for us to remember the features of DGEORGE syndrome. They have cardiac abnormality, interrupted aortic arch, truncus arteriosus, or tetralogy of Fallot. They also have abnormal faces, timing aplasia, cleft palate, and hypocalcemia or hypoparathyroidism. Then we also have Williams syndrome. Williams syndrome mostly occurs spontaneously for unknown reason, but there are also familial cases reported, and it involves deletion of chromosome number 7. And they also have abnormal faces as well. And for the blue eyes with story pattern, it may be apparent in about 50% of children in this disorder. But it is more apparent in those who have blue or green eyes. Those with darker eyes may be difficult for us to see. They may associated with supravalvular aortic stenosis, hypercalcemia, low birth weight, developmental delay, short stature, increased incidence of umbilical and inguinal hernia, and hyperacusis. Okay, next we proceed to the assessment. For the history taking, in general, we need to ask about comprehensive patient and family history of intellectual disability, any previous gynecological or obstetric history of the mother involving infertility or any fetal loss. And we also need to assess maternal health status during pregnancy with the involved child, including use of tobacco, alcohol, and drugs, their lifestyle, any other risk factor for sexually transmitted disease, weight gain or loss, sign of infection, serious illness or injury, as well as surgery or hospitalization. So the history of the child, we need to ask about the birth history, the length of the pregnancy, prematurity, onset of labor, or any rupture of membranes, and duration and cause of labor and type of delivery, or is there any complication. And we need also to check for the APGAR score at 1 and 5 minutes, and as well as their birth weight, length, and head circumference measurement, and we plot on appropriate growth charts. The parents should be asked about any illnesses, feeding or sleeping difficulties in the newborn period, and any problems with sucking and swallowing, as well as the baby's general disposition. This is history based on age. We can focus more on newborn. Is there any dysmorphic syndrome or microcephaly? In early infancy, in between 2 to 4 months, any failure to interact with the environment, concerns about the vision and hearing impairment. For later infancy, around 6 to 18 months, any gross motor delay noticed by the parents. For toddler 2 to 3 years old, any language delay or difficulties. For preschool, we can ask about language difficulties as well. Any behavior difficulties, including play with their peers, and any delay in fine motor skills, cutting, coloring, and drawing. And then for school age, we ask about the academic underachievement and behavior difficulties as well. For physical examination, we start with anthropometry. We measure the height, weight, and head circumference, and we plot the growth charts. If the patient have any short or tall statures, any microcephaly, then we also need to observe for any dysmorphic features in the patient, and examine and we need to do examination of major organ system to rule out any multi-organs involvement and comorbid medical conditions. For example, heart problem. And then we need to do neurological examination for any sensory or visual impairment, abnormalities of muscle tone, for example, spasticity, hypotonia, and then the reflexes, hyperreflexia, any involuntary movement, chorioathetosis. for the investigation, the goals of evaluation is to identify a particular disorder in order for us to allow provide more information to the family about the associated prognosis, the comorbidities, anticipation of the future needs, and whether any treatment is available. So we can do genetic study, chromosomal testing, which is the chromosomal microarray analysis, metabolic neuroimaging, as well as electroencephalography, EEG, if epilepsy or epileptic syndrome is suspected. For the genetic testing, we can do it in family history of consanguinity, history of multiple miscarriage, or family history of infant death, and baby with dysmorphic features, a failure to thrive or stature abnormalities, and if they have abnormal tone. For metabolic testing, we can do episodic. If the baby have episodic decompensation, seizures, any developmental regression, failure to thrive, or abnormal neurological exam found. In inborn error metabolism, the basic investigation, we can do ammonia, glucose, lactate, blood gases, and ketostate, as well as uric acid. For neuroimaging, we do if there is seizures, progressive or degenerative neurologic symptoms, microcephaly, macrocephaly, and focal neurological deficit. As for the management, the goal is for us to strengthen the areas of reduced function. We provide ongoing family support. We prevent or minimize further deterioration in the child's cognitive adaptive function relative to their peers. And we promote optimal individual functioning in society. Medication is not useful to treat the core symptoms of intellectual disability. So we give supportive care. And it involves the primary care and multidisciplinary management. We need to do periodic re-evaluation, and we can give educational services to the family. And we can promote leisure and recreational activities, family counseling, as well as we treat the associated condition. Next is prevention. We have primary, secondary, and tertiary. Primary, we totally avoid this incident, in which we can avoid consanguineous marriage, reduce prenatal alcohol intake, newborn screening for metabolic disease, routine childhood immunization need to be done, and appropriate prenatal care, for example, adequate folic acid and prevention to delayed exposure. Therefore, secondary, we can treat the underlying, for example, a dietary restriction or other intervention in children with treatable IEM, thyroid hormone replacement for hypothyroidism, treatment of vision and hearing impairments associated with intellectual disability, and management of seizures and other coexisting medical disorders. For tertiary, the aim is to maximize the function and quality of life of the patient. So we need to do early identification and establish accurate diagnosis, and we provide appropriate supports and services or resources to the family. And we treat the comorbid conditions, associated conditions, or coexisting conditions. That is all from me.
Any questions? No. Ada soalan?
Can I add something? So in the physical examination, I think we should also look for signs of neurocutaneous syndrome, like the neurofibromatosis or the tuberous sclerosis, because the complication of this neurocutaneous syndrome also it can lead to the child having epilepsy and also learning difficulties, intellectual disability also. What do the presenter think about? Should we or should we not?
Ni siapa ni? Siapa yang tengah cakap ni?
Hakimi. Okay.
Give me examples of neurocutaneous syndromes.
So among the common ones is the neurofibromatosis, tuberous sclerosis, stage Weber.
Apa? Stage Weber syndrome, tuberous sclerosis, okay, neurofibromatosis, okay. So all those also are included lah by right. Yeah, it's supposed to be that. It goes under, no, it doesn't really go under dysmorphic features, but specifically you look for neurocutaneous syndrome. Yes, that's correct. Okay.
Thank you, Tengku.
Terlepas satu. Okay. Other than that, that's fine. Because the reason why I didn't ask for you guys to give me your slides first, because all 4 topics, it's not really, we don't really have hard facts for this. I mean, there are facts, but nothing that needs to be double checked, right? Isn't it? But yes, you look for neurocutaneous syndrome, you look for the signs of dysmorphism. Dysmorphism, depending on what type of dysmorphism, what type of syndromes you're looking for, whether it's signifying fragile X syndrome or something that signifies things like trisomy 21. Okay, but a lot of times the thing about being about dysmorphic features is that if you are doing a short case, just a general rule, if you are doing a short case and you think that the child looks dysmorphic or doesn't look quite normal, ask yourself objectively what are the not normal things, right? Don't just say that the child looks dysmorphic because the child looks different to you. You must be able to objectively say that, look, the child has upslanting eyes with epicantic folds together with, so that shows trisomy 21, right? If the child is of Chinese descent, obviously epicantic folds will not be a dysmorphic feature, isn't it? If it's a single thing, right? If the child is of Chinese descent, the only thing that the child has is epicantic folds, you wouldn't mention it as a dysmorphic feature, because lots of Chinese people have epicantic folds, right? But if the child has epicantic folds, in addition to low side ears, in addition to brachycephaly, in addition to what else? In addition to upslanting eyes, in addition to a slightly large tongue, then you would mention that the child is dysmorphic. All right. So be very careful when you think that the child looks different. Ask yourself what objectively is different about this child. If you cannot list 2 or more features that are different, stop yourself from labeling the child as dysmorphic before you take a look at the parents. All right. So just be very careful before you label a child. Okay. Yeah, adolescent health problems. Sadia.
Yes, okay. So let's proceed with adolescent health problem. Okay. So these are my outline. So we're gonna see just a brief about introduction, and then we're gonna proceed with the assessment and the range of health problems that are possible happen in among adolescent. Okay, next. Okay, so adolescent is actually a phase. It's a phase of a transition from childhood to adulthood. So usually it's from puberty to 18 years old, but it's not fixed. And during this phase, it involves many changes based on biological, psychological, as well as social. And it can be divided into early adolescent, mid-adolescent, and late adolescent by age. For early adolescent, it's from 10 to 14. And for mid-adolescent, it's from 14 to 17, as well as late is 17 to 19. Okay, next. Okay, so these are the 15 leading causes of death among adolescents aged 15 to 19 years old from 1999 to 2019. This is actually a study done in US. Okay, so you can see the leading cause actually due to accident, suicide, as well as homicide. So like the diseases such as neoplasm, heart diseases, congenital problem, infection like influenza and pneumonia, metabolic like DM, as well as chronic lower respiratory disease, severe cerebrovascular diseases, as well as any neoplasm disease, septicemia, death due to pregnancy, childbirth, and the puerperium, as well as legal intervention, and last one is anemia. So all of these are very rare, but it can happen. Okay. So next. So this the assessment is based on this mnemonic, HEEADSSS. So first is home, education or employment, eating, activities, drugs, sexuality, suicide or depression, and as well as safety. So these this mnemonic actually will guide us on what are the questions that we're going to ask the adolescent in order to identify if there's any problems. Okay, next. Okay, so so these are the questions. So from home, we need to ask the adolescent who lives at home with the adolescent and where actually they live. So about the room, the condition of the house itself, and how many siblings that they have, and the ages, and their siblings are healthy, the parents, the health of the parents, and what do the parents do for a living, and how do you get along with your parents or siblings if there's any problem, like family problems. Is there anything that that the adolescent want to change about the family? So all of these questions is basically we want to identify any problem that might comes from the home itself. Okay, next we have to ask the questions regarding the education. So what are the things that we want to ask is basically about the school itself. So when we ask about the school, we need to ask what grade do they in, and then any recent changes in schools, like multiple changes in schools, and if there is, so we need to ask the reasons. And then we also need to know about if there's any favorite subject or the least favorite subjects and why, and how about the recent grades, so that we can assess the education performance at school, and then we can see the progress of the education performance. And we also need to identify if there's any kind of problem with behavior at school, like skipping schools, have they ever been suspended, and we need to also assess the future plan of the adolescent. So like what do they want to do when they finish school? Do they have a plan? And if they have, then what is it? And then how do they get along with the teachers, with the friends at home? And do not ever forget to ask about bullying. Okay, next we need to also ask about employment, because sometimes adolescents, they don't go to school, or they do both. They work and at the same time they also go to school. And then later we also need to ask about the eating habit. Okay, we first we need to assess whether they have insecurities about their body, if there's anything that they want to change, how about their weight, and then is there any, like, do they keep on dieting, want to reduce weight, and why? And we also need to ask about the exercise. Do they rarely exercise, or do they do frequently? And then ask also about the feelings regarding the weight. If they have like overweight issue or obesity, then we need to assess how do they feel about that. And then if they feel worried, how often, and what about the eating habit itself? Is there anything? Is there any episode of eating out of control? And then we also need to assess if they do something, like if they eat a lot, they do like a compensatory behavior, like vomiting, like make themselves to vomit out again in order to control the weight. So we need to assess all of that. This is basically what we learned in psychiatric posting, if you guys still remember. Okay, next. Okay, for activities, so we need to know, do these adolescent, do they hang out with friends? Whether they hang out with same age, or elder than them, or younger than them, and need to ask why. And then about the sex of the friends that they like to hang around with. And then ask about, do they have lots of friends, or they have a small group of friends, or they don't really have friends. And then we also need to ask whether they love to go to school or hang out with friends on weekend more often, more than staying at home, and then ask about if there's any involvement in sport or exercise, their hobbies or interests, and how much the involvement in technology like TV. And currently, of course, we need to ask also about the gadget, iPad and so on, smartphone. And then we also need to identify if there's any involvement with police, or do they belong to gang, because that is also one of the issues. Okay, next about, is there any drugs that they actually take? Okay, so under drugs, there are several questions also that need to be asked, like when they go out with friends, and do most of people that they hang out with like drink or smoke, because we want to identify if there's any peer pressure or influence by friends. And ask them also, do they do drugs, do they drink, and how much and how often, and why. Sometimes they do that because they want to escape from their problems, so we have to identify it. And we also need to ask about, other than drink and smoke, we also need to ask about involvement of drug abuse, and we need to identify the type. And then we also need to identify the frequency of taking drug, and how much each time, and how often. Okay, and then next one is sexuality. So sexuality, we need to ask if they are in a relationship, since when, and we also need to ask, do they have sex? Do they have multiple partners or just one partner? And while doing sex, do they take any precaution, like using any type of contraception? And do they have have they ever been pregnant or had an abortion before? And then have they, if let's say they are active, sexually active, then we need to ask if they have checked for STI. And we also need to ask the knowledge about STI itself and how to prevent it. Okay, and then for females, ask about menarche. This is very important. Okay, about the LMP, the menses itself, whether it's regular or irregular, and also ask about the breast self-examination practice if they do at home. And then for males, ask about the testicular self-examination practice. But okay, next.
Okay, wait, you guys realize, right, all these questions you cannot just ask at one go, right? It's like over multiple visits with the same adolescent, like over a few months. But nobody's gonna answer. Nobody's gonna answer truthfully. And also, when you're talking about sexual activity and sexuality are two different things. But when you're also asking about sex, make sure that you need to ask them what their definition of sex is, right? Some people may think just sex is actually only just penetrative sex, not including anything leading up to it, right? So oral sex, they may not think that is sex, even though that is actually part of sexual activity. And you can also get STDs via oral sex, isn't it, right? They may think it depends on what they understand. It also depends on what sexual education they had previously. That is why education in any situation is important, because only by educating themselves, people will be able to protect themselves, right? Okay, so continue.
Right. Okay. So next.
About suicide and depression.
Okay, wait. My slide is not moving. Okay. All right. So I proceed. So for suicide or depression, so we need to ask about the sleep pattern. Okay, if there's any difficulty in sleeping, and has there been any change in the appetite? So ask about whether there is a loss of weight or increase in appetite as well. And do they mix around with others, or they tend to isolate themselves from people? And do they have these kind of feelings like hopeless or helpless? Because we learn these kind of feelings can bring to suicide. Okay, so we need to identify the risk. And also, we also need to ask politely with a correct way about the suicide, if there's any attempt or if there's any thought even. Okay, so if let's say there's any attempt, we need to ask when, how frequent, and do they ever how frequent, and what are the method. Okay, all right. So next is about the safety. So we need to ask about the have they ever been seriously injured, and while driving a car, do they wear a seatbelt, and do they use safety equipments like during sports or other physical activities, for example like helmets during biking, and then is there any violence at home involved with parents or siblings? Does the violence ever get physical, and have they ever been physically or sexually abused by anyone, and about the bullying itself, and then about if there's any involvement in fights at school or neighborhood, and ask about the current also. Are they still getting into the fights? Okay, so next. Okay, so these are the range of health problems that can arise from among adolescents. Okay, so there are many actually. So these are just some examples. So first is chronic illness. So adolescent, even they are young, so they can come with chronic illnesses as well. Next is somatic symptoms, and then and mental health problems also an issue currently. Eating disorder, okay, health risk behavior as well. And then for females, of course, menses problems. Okay, so next. So now we look at the chronic illness. So there are many, but here are some of the examples. Okay, like asthma, epilepsy, diabetes, cerebral palsy, juvenile idiopathic arthritis, or sickle cell disease. Okay, so basically this chronic illness can cause many effects, okay, biologically, psychologically, and socially in this phase. Okay, for biologically, they can cause delayed puberty or short stature. Okay, like stunted. Okay, and then psychologically, they become less mature behavior, and they tend to play sick role, lack of self-esteem, and to some extent, they can develop depression. Okay, for social, they become dependent. Okay, dependent to surrounding people, and then they don't have friends, and they like to isolate themselves, maybe due to the lack of self-esteem just now. And then they also tend to have lots of absentee in school and also social events. Okay, next. So somatic symptoms, as we learned before in previous posting, okay, it is actually a physical symptom that suggests illnesses or injury, but cannot be explained by any general medical conditions, substances, or mental disorders. Okay, the common somatic symptoms like fatigue, headache, abdominal pain, backache, as well as dizziness. Okay, so if let's say adolescents come with this kind of complaints, so we must exclude organic diseases first. So we must ask question, take a proper history and do physical examination and a thorough investigation that we think of. Okay, and then we also need to dig into probable social factors like bullying or family problems that can lead to somatic symptoms. So if these too severe, if the somatic symptoms become too severe, they can affect the quality of life of this adolescent. Okay, from the academic perspective, social perspective. Okay, so it will affect the life as a whole. Okay, next. Okay, so mental health problems, it is very common among adolescents, about 11%, and 7 to 14% of them have self-harm. Okay, usually the causes of self-harm, they do that because in order to escape from interpersonal crises, and it is a way to show their distress, and even because they attempt to suicide. Okay, so next. So eating disorder is due to lack of due to insecurity, basically. Okay, they feel dissatisfaction of their body, and it is commonly among female, but it can also happen in male as well. So the concern here is actually these two problems, which is anorexia nervosa as well as bulimia nervosa, because these two diseases not just cause not just affect the social, the psychosocial, but it also affect the body of the adolescent itself, because it can lead to complications such as hypothermia, amenorrhea, electrolyte imbalance, bradycardia, and it also can lead to death if, let's say, it is not treated lah. Okay, so next. So health risk behavior, of course, it is also known as risk-taking behavior lah. For example, because as we know, during adolescence, they are very curious, so they want to try lots of things. So that's why they tend to be involved with this kind of behavior, which is smoking, drinking, drug abuse, as well as sexual promiscuity. Because most of them, because they are looking for pleasure and excitement in new experience, and then they feel like they are independent from parent, or it is also some sort of rebel action. Okay, and sometimes they do that while having lacking of knowledge about the consequences as well. And also, another reason is because of peer pressure. Okay, next. Okay, so menstrual problems among female, it is very common, which is 75%. Okay, and before we identify the problems in the menses, of course, we need to know what is the normal. So the average menarche is around 12 years. Okay, the menstrual cycle initially when starting, it is longer, but eventually it become regular, like a normal. Okay, normal duration menses like 7 days or fewer per cycle. Depends on people actually. Okay, some of girls they have longer duration, some of girls they have shorter, but as long as the cycle is normal, then it's fine. And then the blood flow also, we need to know whether it is heavy bleeding or not, because this is very important, because the heavy one can lead to anemia and so on. Okay, so the problems that we want to identify, if there is any delayed onset, or if there is amenorrhea, or any irregularity, heavy flow, or dysmenorrhea, because all of this is very, sometimes it is an emergency, it's not emergency, it's like caused by more sinister diseases, such as like dysmenorrhea, for example, what we call that, dysmenorrhea, endometriosis. Yeah. Okay, next. Okay, I think that's all for me. So the references. Is there any question?
Can we go back to the first just now? Can we go back to the first slide for a while? Dia awal lagi. Lagi? Let's start from the beginning. Okay. Okay, next. 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 I'm going backwards pula. Next. Next. Okay, these are all like questions. But it's also important if you are talking to teenagers, like you're very aware when you're talking about them, about how they are dressing. You know, if the teenager, every time she sees you, he or she sees you, she is like always in long sleeve shirts, right? hoodies and long sleeve shirts, then you might have to think about, and is very shy about showing off their forearms. You might have to think about self-harm, right? Like cutting, because that's where they tend to cut what, their wrists, their forearms, isn't it? All right. Generally, whether they are well kept or not. Also, forearms, also drug use, intravenous drug use. Look for any scars. So generally, next. Okay, what's happening? Next. 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 No, next. Next. Just run through. Let's continue. Just run through. When it stop. The just run through here. Okay. Okay, last one.
Okay, so I will be the last presenter.
Oh, I was on mute just now. Yeah, I was on mute just now. You guys heard? You guys? Yeah, Intan tunggu jap. I was on mute just now, right?
No, doctor. We can hear you
No.
actually.
Okay, no, because only whatever. Okay, continue.
Okay, so proceed with palliative care. Okay, next. Okay, this is my outline. So first definition and then goals. The third one is who needs palliative care, principle of palliative care, elements, management, and also end of life care. So for the definition, next. Okay. 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 So for the definition, based on World Health Organization, so palliative care for children is the active total of the children of the active total care of the child's body, mind, and spirit, and also it involves giving support to the family. And then it begins when the illness is diagnosed, and then continues regardless of whether or not a child receives treatment directed at the disease. And then based on the Nelson textbook, the palliative care approach is defined as patient and also family-centered care that will optimize the quality of life by anticipating and preventing and also treating the suffering. Okay. Next. Okay, so the goals of the palliative care, we want to improve the quality of life, and then we want to maintain the dignity of patient and also the family members, and then we want to ameliorating the suffering of the seriously ill child. Okay. Okay, next. Okay, so next about the category of the condition that appropriate for the pediatric palliative care, which is we have 4 categories. So the first one is when curative treatment is possible but may not succeed. For example, like in those who have advanced cancer or cancer with poor prognosis. The second one is when there is intensive long-term treatment aimed at prolonged life. For example, like the patient with cystic fibrosis, chronic immunodeficiency, HIV, chronic or severe respiratory failure. The third is when treatment that is exclusively palliative after a diagnosis of a progressive condition is met. For example, like in a patient with trisomy 13 syndrome, or we call as a Patau syndrome, and then in the patient with severe form of osteogenesis imperfecta. The fourth one is when treatment are available for severe or non-progressive disability in patients who are vulnerable to health condition. For example, like in patient with a severe spastic quadriparesis or with difficulty in controlling the symptom, and also in a severe brain malformation, for example, like AV malformation. Okay, next. So the principle of integrated palliative care. The first one is we want to respect the dignity of the patient and so the family members. And then we want to give access to comprehensive and also compassionate palliative care. And it actually use of interdisciplinary resources. And then we want to give acknowledgement and also give support for the caregiver. And also we want to give commitment to quality improvement of palliative care through research and also education. Okay, and okay, so for the hospice care, it actually the treatment program for the end of life. It actually provide the range of palliative care service by involve the interdisciplinary team, and then the person who can receive the hospice service is, for example, the patient who have a prognosis of death within 6 months, when there is a cessation of curative effort for the children. And when there is a curative effort, may continue while there is the higher level of coordinated end of life service may be applied. And then next is about the bereavement. So bereavement is same like we learned before. So bereavement means that the process of psychological and also spiritual accommodation to death. And the grief means that the emotional response which is caused by loss, including pain, distress, physical and also emotional suffering. But usually for the parents who have their child with terminally ill patient, they actually have a difficult issue to talk with the child about their child's imminent death. And then somehow, parents are more likely to regret not talking with their child about the death than having done so. Okay, next is about the developmental perspective of a child understanding about death. So we have next. So we have 4 phases. So the first one is sensory motor. So sensory motor, it involves the children up to 2 years old. So during this time, the children understand that death is means separation, means that there is no concept of death. And then the associated behavior is like there will be a prosthetic and also difficulty of attachment to other adults. And then the second phase is pre-operational phase. So it is around 3 to 5 years old. During this time, the children will have a trouble grasping meaning of illness and also permanence of death. And then during this time, the children understand that the death is like punishment. And then next is a concrete operation, which is between the age of 6 to 11 years old. So during this phase, actually they slowly start to understand what is the meaning of death. And then the last one is the formal operation, which is involve the children more than 12 years old, and they know that the death is actually a reality and it is irreversible. Okay. Next. Okay. This one is a developmental example of developmental question, talk, and also concept of dying with a responsive strategy. So as you can see that in the age of months to 3 years old, so the example of typical question and statement about dying is like, "Mommy, don't cry. Daddy, will you still tickle me when I'm dead?" And then during this time, the child has limited understanding of event, future, and also past, and also the difference between living and non-living. And then the child also may have a sense that something is wrong. That is often viewed as a continuous with life. And then the analog is like just being awake and being asleep. So the strategies that can be done is like we optimize the comfort and also the consistency, and then we use a soothing song, words, and also touch. Like for example, like I will always love you, I will always take care of you. Okay, next. Okay, this one is during the age of 3 to 5 years old, which is the typical question like I did something bad and so I will die. Can I eat anything I want in heaven? And then their behavior during that time is their thought is the concept are simple and reversible, and there is a variation between reality and also fantasy. And then the child may see death as a temporary and reversible and not universal. And then the child may feel responsible for the illness. And also death may be perceived as an external force that can get you. So the strategy that the response that we can give like assure child that illness not her fault, and so provide consistent caregiver, promote honest simple language, and then we can use books to explain the life cycle and also promote question and answer. For example, like you did not do anything to cause this. You are so special to us, and we always love you. For example. Okay, next. Okay, this is between the age of 5 to 10 years old. For example, the typical question like, how will I die? Will it hide? Is dying scary? And then during this time, the child begins to demonstrate organized and also social thought, and thinking become less esoteric, and the child begins to problem solve concretely, reason logically, and organize the thought coherently. However, the child has limited abstract reasoning. And during this time also, the child begins to understand what is the meaning of death, and it is know that the death is real and permanent. And then it also know that the death means that your heart stops, your blood does not circulate, and you do not breathe, for example. And then this response we can give like be honest and provide specific details if they are requested, and also help and support the child need for control. And for example, like we will work together to help you feel comfortable. It is very important that you let us know how you are feeling and what you need, for example. Next. Okay, so this stage is around 10 to 18 years old. So the typical statement like, I'm afraid if I die, my mom will just break down. I'm too young to die. I want to get married and have children, for example. So during this time, they already have abstract thinking, and also the logic thinking. And also during this phase, the child start to understand the death is irreversible and also universal. So the child needs reassurance of continued care and love. And so what we can do, like we reinforce the child, and also we reinforce the child's self-esteem and also self-respect, and then allow them to have their privacy, independent, and also give them support. Okay, next. Okay. So the element of palliative care, which is involve the pain management, expertise with feeding and nutritional issue, and also we manage the symptom. Okay, first for the pain management, so we need to identify the pain and assessing its severity, and then and then the treatment is to eliminate or to reduce the pain. So we use the WHO analgesic ladder approach and avoid the unnecessary painful procedure. Adequate doses of analgesic should be administered. We use the by the clock approach, and then sufficient dose and appropriate pharmacological formation. And appropriate opioid dose is the dose that effectively relieve the pain. Okay, next. So this is the WHO analgesic ladder we use in the pediatric. So for example, like the patient, the child has mild pain, so we can give step 1. So we can give non-opioid. For example, non-opioid, if the age is more than 3 months, we can give ibuprofen or paracetamol. If the age is less than 3 months, we can give paracetamol. And then it can plus minus with adjuvant. So adjuvants, for example, like antidepressant, anticonvulsant, antispasmodic muscle relaxant, biphosphonate or corticosteroid. And then after that, we can step up if the pain persists or increase. So for the moderate or severe pain, we can give a strong opioid. For example, like morphine or fentanyl, oxycodone, hydromorphone, or buprenorphine. So it can plus minus with non-opioid and also plus minus with adjuvant. And also consider prophylactic laxative to avoid constipation. And then before I had mentioned about the dose by the clock. So dose by the clock means that the time doses is based on the drug half of life. For example, like this drug have the 2 hours of half life. So before it come to the to the end of 2 hours, we need to prepare the next dose because we want to avoid any pain to recur back. Okay, next. Okay, next expertise with feeding and nutritional status. So we can give
Intan,
yes, doctor.
Expertise.
Expertise. Oh, sorry, doctor. Expertise.
Same thing with hospice just now. HOSPICE, hospice.
Hospice.
Okay.
Hospice.
And expertise. Okay.
Expertise. Okay. Thank you, doctor. So in this we can provide enteral or parenteral nutrition. So points to be considered is like we identify intervention that may improve anorexia or cachexia, for example, and then we need to review the potential adverse effect of the enteral nutrition, for example, like aspiration pneumonia, and then review that children can live comfortably for a long period of time with minimal fluids and also nutrition. Next. Okay, so for the management of symptom, it involves the symptom recognition and also assessment. So regularly assess the child's psychological, social, spiritual, and also physical symptoms. So the core principle of symptoms, it involves we treat the underlying causes, and then we can give drugs, behavior, physical, and also supportive therapy. And then if there is a persistent symptom, we can treat with a regular interval medication. And if it's severe or uncontrolled symptom, it should be involve the medical emergency, so we can have active intervention and also avoid inappropriately invasive and painful routes of drugs administration. And then we must anticipate the side effect of the medication also. Okay, next. So the management of symptom, for example, like if the patient has dysmea, it can be caused by the pulmonary disease, or it can be due to the anemia, air obstruction from the tumor, or it can be due to the heart failure from the cardiac disease. So the management is we can give morphine immediate release because this one can actually prevent any respiratory distress, and also we can give lorazepam to reduce the anxiety, and also we can do suction secretion if present, give a comfortable loose clothing, and then fan to provide cool, and also behavior strategy including breathing exercise. Next. So there are the symptoms like nausea and vomiting. So it can be due to the radiotherapy or chemotherapy, and the other causes like opioids, NSAID, and also constipation. So the management is we can review the prescription of drug and then prevent the constipation. We can give anti-emetic medication and also manage the electrolyte abnormalities. Okay, for the constipation, so the common causes like immobility, weakness, poor oral intake, and also drugs. So the management that we can do like encourage increase fluid intake, increase the fiber in diet, and also we can give anti-emetics and also laxative. Okay. For the fatigue, it can be due to the anemia, infection, pain, impaired nutrition, sleep disturbance, depression, anxiety, and also medication. So what we can do, like we give a treatment of depression, anxiety, or sleep disturbance if this is the causes. And then we encourage the gentle and also regular exercise. And then we treat the anemia if this is the causes. And or we can use of psychostimulants, for example, like methylphenidate. Okay, so the last one is about the end of life care. So what's in the end of life care is we need to manage the end of life symptoms, and then it should be involve the ongoing preparation and also support to the patient and also to the family members. And we can discuss with the family members about the selection of a preferred location of death, and then we can also discuss about the autopsy or the organ and also the tissue donation. And the last one is provide provision of the bereavement support and also counseling to the family members. Okay, so that's all I think. Okay. Any question?
I would like to ask, how did morphine act as a treatment for patient with dysmea? Because as we learned like before, it causes respiratory depression, right? So how can the morphine help the dysmea?
I think it's about it's related to the prostaglandin, if I'm not mistaken. I'm sorry.
Intan, where do you get this from? This part from?
Which one?
The morphine part. Managing breathlessness in palliative care, exact mechanism of morphine by which morphine alleviates breathlessness is unknown. However, opioid-induced vessel dilation in pulmonary vasculature has been demonstrated in animal studies. This is only used in palliative care, okay? They also don't know now, but it works in palliative care, but you don't use morphine to alleviate breathlessness in any other situations. Okay. Also, if in palliative care, morphine also is used in terms of pain relief, isn't it? Right. So it's kind of like you're using it in a dual purpose kind of way. Okay.
Okay. Thank you, Doctor. Any other questions?
Many palliative care in children, it depends on quite the age of the child. It also depends on the level. It depends more on the level of maturity of the child, isn't it? A 10-year-old can have a level of maturity of a 6-year-old. Even a grown-up can be like an immature teenager, isn't it? Right? And also how much and also culturally, also like I think Asians tend to be a little bit more I'm the parent, I shall decide everything by myself. And as opposed as I'm the grown-up, I'm the parent, I'm the grown-up, I shall decide, as opposed to somebody in the Western countries, isn't it? Culturally, we are different. You guys got any questions? No questions, then I can share a video, because I think if I leave a link, nobody will watch it.
Okay, Doctor.
Guys, want to watch a video or not? Yes or no?
Yes,
Okay.
Yes.
Okay, so
Doctor.
can the person no longer sharing already, right? Okay, wait, let me check. Share. Screen.
Juliana Snow has a neuromuscular disease that's slowly taking her life. She can't walk or breathe on her own or even use her hands to play with glitter.
There's no such thing as too much.
Guys, can hear or not?
Yes.
Yes, Doctor.
Now? Okay, wait.
No such thing as too much, okay?
The next time Juliana gets a cold or any infection, her body will be too weak to fight it off.
What do the doctors tell you is likely to happen if she were to get another cold?
She will most likely die if she gets another cold. You okay?
Juliana's doctors presented her parents, Steve Snow and Michelle Moon, with two devastating options. Juliana could die at home in her bedroom, comfortable, surrounded by family. Or she could go to the hospital, where treatment likely couldn't save her, or even if it did, she would likely have a terrible quality of life.
Everyone told us there is no right answer.
So Michelle and Steve asked Juliana something almost no parent could even fathom. When she was just 4 years old, they asked her what she wanted to do, go to the hospital or go to heaven.
You blogged about it.
Yes.
So let's take a look.
Okay, so me. Juliana, if you get sick again, do you want to go to the hospital or stay home? Juliana, not the hospital. Me. Even if that means you will go to heaven if you stay home? Juliana, yes. Me. And you know that mommy and daddy won't come with you right away. You'll go by yourself first. Juliana, don't worry, God will take care of me. Me. And if you go to the hospital, it may help you get better and let you come home again and spend more time with us. I need to make sure you understand that. Hospital may let you have more time with mommy and daddy. Juliana, I understand.
Juliana told her parents she hated the hospital, especially a procedure called nasotracheal suctioning.
So basically you stick a tube on a suction machine and you stick it up the nose, down past the tongue, back into the throat, as deep as you can go, and you start suctioning. If given the choice of me or one of the other respiratory techs, she would usually ask for me to do it.
Was that hard to do?
Yeah.
Could you watch her go through that again, do you think?
If I had to, I'd do it.
Would it save her life to do it again if she were to get an infection?
I don't think so.
Michelle and Steve say when the time comes, they'll honor their daughter's wishes to die at home and go to heaven over the hospital.
Some parents wouldn't have consulted a child so young. They would have said, we're the parents. So you asked your daughter at the age of 4, what do you think? What should we do?
Juliana had to go through hundreds of rounds of nasotracheal suctioning. She knows exactly what that was. She was awake for every single one. She knows what that is. So I think she has a right. I think she has a say.
Juliana's doctors told CNN she's an exceptionally wise 5-year-old, and they support her parents' decision to carry out her wishes. For now, Juliana's enjoying her life with her parents, her big brother Alex, and her princesses.
Are Elsa and Anna, I forget, are they cousins or?
They're sisters.
Oh, they're sisters.
It's Anna.
Oh, it's Anna. I said Anna. It's
Yes.
Anna. I'm sorry.
She forgives you.
What are your realistic hopes for her for the rest of the time that she does have left?
Be comfortable, be happy, feel loved.
What's gotten you through it?
Faith. Whoever you may pray with, wherever you may be, I can guarantee for certain God listens to you and me. Faith that she will be in a better place when her time comes, and we can go join her someday, and this will all pass away.
What do you want people to remember about Juliana?
Her heart. She is just so much love. So much love.
It's just so sad. Elizabeth joins us now. Juliana talked about what she thinks heaven will be like. What did she say?
Right, her mother had a discussion with her about that, Anderson. And her mother says that what they discussed is that in heaven, she won't be in a wheelchair. She'll be able to run around outside. She'll be able to play. She'll be able to eat, none of which she can do right now.
And her doctors are supportive of the parents' decision?
They are. I interviewed several of her doctors and nurses, and all of them were supportive of the choice that her parents have made. I want to read you actually two of them. Her nurse in the intensive care unit, who was with her over several hospital stays, said, "There is no cure for her, and I want her living and dying in her princess room at home, surrounded by her family, not by the cold technology of the hospital." And then her pulmonologist, Dr. Danny Shaw, told me, "For her, there is no light at the end of the tunnel. She doesn't have a long time left to live. I have the utmost faith in her mother and in her father. They're phenomenal parents, and they have her best wishes at heart."
Okay, so that's one video for you to watch and think about lah. Okay. There are other videos also. I think there's one from the Singapore General Hospital, which would be more closer to what we would do lah, I guess, because Singapore. But anyway, any questions? If there are questions, then we can stop. Next week is also on Tuesday, right? The presentation.
Yes, doctor.
I saw the emails this morning, but I haven't gone through it yet. I'll go through it first. In the future, if it's with me, you send your presentations individually, because it's easier for me to just directly deal with the person who had done the presentation rather than to go through the middle person.
Doctor, if we re-email you again?
Boleh je, up to you guys lah.
Okay, boleh doctor.
Because if not four at one go, then I have to go through the person who emailed me a bit troublesome lah, isn't it? Right? If you want to email me again, fine. If you don't, it's also okay. Everybody off.
Okay, doctor, will do.
Okay. Okay. Any questions not? Any questions not? Kalau tak ada, then can just can end. Somebody already left actually. 26 je. Somebody left halfway, is it?
Not really sure, doctor.
Ya, tinggal 26. Patutnya 28 kan?
Tadi yang masa awal tadi 28 tu because someone is using two device.
Dan patutnya 27 lah kan?
27.
Seorang hilang lah tu. I mean group monitor siapa yang hilang, tanya dia kenapa hilang. Okay?
Okay, doctor.
Okay.
Thank you very much, doctor.
Thank you, 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 doctor.
Okay, bye.